I'd like to tell you that I'm an associate editor for the American Journal of Medical Genetics, for which I receive an honorarium. I also do consultation for the Centers for Disease Control at the Massachusetts Department of Public Health. The photos that you'll see today are either from my personal collection with consent, from the internet with citation, from journal articles that I've cited, or in the public domain. A few of them have been anonymized by using black bars. And the purpose and goals of this talk are to review syndromes that are common or distinctive, or they represent a model of development or diagnosis. I'd like to illustrate a few additional learning objectives. And these are multiple anomaly syndromes. We're going to exclude inborn errors of metabolism. I'll focus on dysmorphology, pattern recognition, and syndrome delineation. What do they look like? What are the diagnostic criteria? The differential diagnosis? What else will they resemble? And again, in the interest of time, we're going to exclude chromosome abnormality syndromes. I will not be able to discuss pathogenesis, management, biochemistry. I'll mention a few genes. I'm going to keep it light. I want to talk about what's the big picture. And I'll definitely incorporate the patient experience by mentioning support groups. This is to level the playing field. This is a talk that's appropriate for trainees, specialists, and senior staff. I'd like to tell you about some of the resources that will supplement this talk. For starters, there's some common books. Many of you know of the Smith's book, Recognizable Patterns of Human Malformation. The current edition is 2013. There's another handy book called the Cassidy and Allenson book for management of syndromes. And an excellent additional book is entitled Medical Genetics from the group in Salt Lake City. And there's a lot of good stuff online. OMIM, Online Mendelian Inheritance in Man, Gene Reviews, Orphanet. A lot of the support groups have excellent educational materials. Use Google Images with caution. You can't be certain of what's there. There's some NIH-funded articles, and certainly the journals, American Journal of Medical Genetics, Journal of Medical Genetics, American Journal of Human Genetics, and Genetics in Medicine. Now, one way to approach this talk is to take a step back and think, how do you classify all these different syndromes? So the top row will tell you about a familiar way, which is in the Smith's book of the recognizable patterns. And these are familiar clinical descriptions, chromosome abnormality syndromes, such as trisomy 21, 13, and 18, short stature syndromes, Williams syndrome, senile-like appearance, progeria, facial defects. And in parentheses, in italics are the genes, elastin, lamin A, IRF6. Another way to approach a syndrome is by the type of general category. In this case, I'm showing you some skeletal dysplasias. Thanatophoric dysplasia, achondroplasia, hypochondroplasia. And currently, we now know that these are all caused by the same gene, FGFR3. So we've gone from describing them as a skeletal dysplasia to a single gene family, slightly different mutations, but these are all similar. Another approach is to talk about them by their phenotype. What do they look like? And I'm going to tell you about the Noonan-like syndromes, which we call the Rasopathies. So Noonan syndrome, which I think is common, familiar to most pediatricians, is actually caused by several genes. I won't recite the list because these are unfamiliar, but just to help you understand the concept. Related to Noonan syndrome is something called CFC, CARDIO-FACIO-CUTANEOUS syndrome, at least 3 genes, COSTELLO syndrome, 1 gene. And we're going to talk about these in detail, but the concept is that these represent a family of similar phenotypes. Some definitions. We define multiple anomalies by syndrome. It's a word you've heard so many times. The formal definition is that these are multiple anomalies thought to be pathogenetically related, so something causes them. Down syndrome, a chromosome abnormality. MARFAN syndrome, a single gene. And this is in contrast to an association, non-random, pathogenetically unrelated. And VATER association is common to most pediatricians. With more knowledge, sometimes an association becomes a syndrome. Charge used to be an association, but we now know it's caused by a gene, so it's a syndrome now. Sequence is a single known anomaly or mechanical factor. It's a cascade. And Pierre-Robin is the most familiar sequence, also oligohydramnios sequence, or the Potter's facies. So this is my list of the top 10 syndromes. I'm going to read through them, and we'll go through them one by one. And each of them represents something, some example that I want to typify to make this sort of a broader learning experience. So the first one will be VATER association. The next one is arthrogryposis, or multiple contractures. So this represents an association, this represents a sequence. We'll talk about MARFAN syndrome and related to it Loeys-Dietz syndrome, and these are connective tissue syndromes. I'll discuss SOTOS syndrome, which is a very familiar overgrowth syndrome, CHARGE syndrome, which is a craniofacial disorder. And I've already given you a hint about Noonan syndrome and its related COSTELLO CFC syndromes, and these are short stature. HOLT-ORAM syndrome is called a hand-heart syndrome, limb defect. Osteogenesis imperfecta is a familiar connective tissue disorder, also skeletal dysplasia. I'll describe APERT syndrome and CROUZON syndrome, which are craniosynostoses. And lastly, we'll talk about fetal alcohol syndrome, which is a very well-known teratogen. So to begin, the first one is VATER association. So this is an acronym, V-A-T-E-R. Sometimes an extra R is added, VATER, or a C for Voxtrol. Described in 1972 by Kwan and David Smith, there's no single etiology. Again, this is why it's an association and not a syndrome. So it's a pattern, a malformation complex, not a single disease. And people always ask, well, what does it take? What are the minimum diagnostic criteria? And most geneticists would say you need to have at least 3 of the core defects: vertebral anomalies and perforate anus, cardiac, TEF, renal, or radial. And some of the minor features are single umbilical artery and hydrocephalus. I've shown an asterisk for the ones that are most distinctive: the anus, TEF, and the radial. So for example, if a child has a PDA, hydronephrosis, and maybe one hemivertebrae, technically that fulfills the criteria, but that's very weak. This can occur within a syndrome. So you could have somebody who has trisomy 18, which is a syndrome, and they could have the VATER association. Every child with VATER is unique. There are some exceptions to this being a syndrome. There are some forms that are X-linked. These are very rare. Mental disability, mental retardation is not increased. And there are good resources in Orphanet, and there's actually a support group for VATER. So just to give you an idea of how we have come to try to define this, there's an active support group out of the NIH, and they've performed this type of, looks like a complicated Venn diagram, doesn't it? Where they have looked at patients who have the V and the A, vertebral and anal, C and TEF, and different combinations. This is not necessarily for teaching, merely to illustrate that for an association without an underlying cause, you are left to perform a nosologic analysis. And to review the individual defects, this is a cartoon showing you different types of vertebral anomalies: hemivertebrae, butterfly vertebrae, other hemivertebrae. And if they're balanced, you may not get scoliosis, but they're imbalanced, you'll see the structural scoliosis. Now this chest x-ray looks a little blurred, but what it illustrates is both vertebral anomalies as well as a heart defect. There was a coarctation. And heart defects occur in about 50%. They're all different types. There's no specific pattern. These are the different types of TEF, esophageal atresia. These are a variety of radial defects with the thumb as well as the radius. And there is no facies, there's no distinctive facial appearance, and there's no intellectual disability. So one of the reasons for knowing a lot more about VATER associations is because of the differential diagnosis. So the reason a geneticist will spend a lot of time evaluating a child in the newborn period is to make sure there isn't something else going on. Okahira syndrome is a VATER phenotype with the Duane eye anomaly. This means limited abduction and retraction of the eye, and there is a gene called SAL4. Town-Brock syndrome has ear anomalies, SAL1. Holt-ORAM syndrome, to be discussed later, is TBX5. This is an important one, Fanconi anemia, because of the pancytopenia, and this should be addressed. TAR syndrome has bilateral absent thumbs, sacral dysgenesis, caudal regression, all a little bit different from the core complex that is VATER. To move on, number 2, I'd like to talk about arthrogryposis, multiplex congenital, or multiple congenital contractures. So this differs from contractures that may occur later in life. And described in 1970, the cause varies. So it basically is related to fetal akinesia, not moving in utero. It's multifactorial. It's a phenotype, not one syndrome. And you have to look for an underlying disorder. So it could be Wernicke-Hoffmann syndrome, spinal muscular atrophy type 1, which is recessive. There's some types that are distal, and that's a dominant. And there's one type called amyoplasia, which means really no good muscle, and that's sporadic. You look for, in the history, oligohydramnios, fetal crowding. You ask about the mode of delivery. You look for the total pattern. Is there a syndrome? Is there joint fixation, fractures, muscle defect? Is it distal, diffuse, or symmetric? This is a malformation complex, a sequence, and you, as I've said, look for the underlying cause. So these evaluations are usually multi-specialty. There's neurology involved, genetics, people getting radiographs, and everybody has to work together. On exam, I always look for creases, dimples, muscle quality and atrophy, and whether the facial appearance is dysmorphic. The Smith book has an excellent section on this. Orphanet, which is online. Individual diseases, their websites will provide you with information, or gene reviews, again, for some of the individual diseases. There's a very active support group called Avenues and AMC. Sometimes it's good to go back to the original description of a disorder. In this case, Dr. Judy Hall wrote an excellent article way back in 1983, and she titled it Amyoplasia because she was focusing on this kind of a phenotype. A flat face, normal intelligence, and just the lack of muscle. This was a fibrous presentation. And this is the pattern of contractures. Contractures, when you say the word contractures, a very broad term, can involve the upper, lower extremities, can be proximal, distal, and can be flexion or an extension. So from the internet, I can show you a picture of a girl with distal arthrogryposis. Note her casting, so she's got club feet, and notice her hands right there. So this is the pattern here. Normal intelligence, notice she's sitting upright, she's got good tone. Here's somebody with club feet. And this is a much more severe presentation, denervation atrophy. So again, there's a wide range. I've given you just a small sample. Let's talk about MARFAN syndrome, which I think is sort of a core syndrome for most pediatricians. In 1896, MARFAN described this, and he was a pediatrician, and ironically, in retrospect, we think this child may have had Beale's syndrome. And this is caused by mutations in the fibrillin gene, abbreviated as follows. And interestingly, not all fibrillin syndromes cause MARFAN syndrome. It turns out that it can also cause an entity of isolated ectopia lentis. It is autosomal dominant, so it's a genetic disease, can be passed along. And MARFAN syndrome illustrates the way that geneticists try to define the clinical diagnosis for a condition. So experts will gather, in this case it was in 1996 in Ghent, Belgium, and they came up with different combinations of major and minor. It will seem a little bit overwhelming as I show it to you, but in fact this is how we do this. It was updated in 2010, and more weight was put on the aortic root dilation, ectopia, and the presence, our ability now to do the molecular genetic testing. We talk about the skeleton having tall stature, increased arm span, long legs, ectopia lentis upward, high myopia or retinal detachment, aortic dilation, sometimes leading to dissection, pulmonary artery dilation, mitral valve prolapse, spontaneous pneumothoraces, blebs, striae and dura ectasia. It's certainly beyond the limits of this talk to go through each syndrome in great detail, so I hope you'll forgive me for just outlining some of these criteria briefly. And for this syndrome and for other single gene diseases, we do invoke the family history. But I urge you to remember it has to be independently verified. You have to follow the criteria, follow the rules, don't just go by your hunches. And when you're working with MARFAN syndrome or evaluating somebody for a related disorder, you have to exclude the other aortopathies or other reasons for being tall. The main reference is from the Journal of Medical Genetics, but you can easily find this information in Gene Reviews or Orphanet, and the MARFAN Syndrome Foundation is just a wealth of information. So I'm actually going to show you what this article looks like because I can highlight the title, The Revised Ghent Nosology, the first author Lois, and some of the other authors. And this illustration shows you what we mean to have aortic root dilation. So this is the annulus, this is the sinus of Valsalva, this is the ascending aorta, the transverse aorta, but it's this kind of bulging aorta that represent aortic dilation. Now these are the rules, and I'm not going to go through each of them because it is intimidating. But when you are trying to make the diagnosis, if you as a pediatrician want to try to do it before referral, you can try to figure it out. I'm highlighting just one of them here. This is number 3. The aorta is dilated. The Z-score is more than 2, which is twice as large, and you can look at the systemic features more than 7 points. But it is a bit tedious. You have to go through each of these one by one and make the referral then. So there are different phenotypes for Marfan syndrome. So I thought I'd show you starting in infancy. There's the infantile Marfan syndrome. I happen to be been part of this collaboration. And so we talk about this infantile presentation as severe. These are the fingers showing the arachnodactyly. And people talk about whether there's a difference between severe infantile versus neonatal. So what's the difference? Neonatal means that this is a child born to a parent with Marfan syndrome, where it can be mild, can be overlooked, whereas this infantile presentation is dramatic. They often have very severe tricuspid and mitral valve disease. Marfan syndrome can present in athletes as sudden death. Of course, there are many other reasons for sudden death in athletes, but this is one of them. This is from Sports Illustrated, because many years ago, this is an athlete named Flo Hyman who had played in the volleyball team in the Olympics in Los Angeles and then later went on to have sudden death on the court. There were some other athletes. And this comes up from time to time, and you have to be very discreet in your readings and your interpretation. So here's some of the individual features. This is a picture of ectopia lentis, the lens of the eye being dislocated upward. This is what we mean by a truly narrow palate, very narrow. Sometimes it's called Gothic or Byzantine. This is what we mean by the thumb sign. And usually when I'm giving this talk, I ask people, I said, practice yourself. Because there's a fake thumb sign where you can just sort of push your thumbs through. But in Marfan syndrome, the thumb is long, it's lax, and the thumb easily goes down and the fingers easily fold over. This is what we mean by the wrist sign. So it's the 5th digit, the 5th finger, and it's fully overlapping the distal digit, all right? So you can't use your middle finger. It has to be this 5th one, and there's a full overlap there. This is a mother and her son. And if you look, you can see the arachnodactyly in both of them. The mother also has a sternotomy scar from where she had her surgery. And this is a dramatic example of a flat foot. What I can't convey in a talk is the feel of the foot. There is so much laxity that the foot literally crumples in your hand. This is a related disorder called Loeys-Dietz syndrome, a completely different gene, TGF-beta receptor 1, TGF-beta receptor 2, and it's described in the New England Journal. And this is just a composite. I'm just going to quickly show you that they look sort of Marfan-like. I think you'll agree. There's type 2, in which you have translucent skin. These are veins. And this is just a little sign I thought I would show you. This is a bifid uvula. So something as simple as that you could notice in your office can be assigned to it. I'm not going to belabor this syndrome. I think it's more than a general pediatrician would need to know, but just to convey the concept that there are syndromes that occur in people who turn out not to have Marfan syndrome. So we'll move on. SOTOS syndrome is a good example of an overgrowth syndrome because it's common, and I think it's memorable. In 1964, Dr. SOTOS, Dodge, and Crawford, who were at MGH, described this in the New England Journal. It's caused by the gene called NSD1, single gene, autosomal dominant, which would mean a recurrence risk of 50%. It's rare, though, that we've seen adults have children. So this is also a clinical diagnosis. A distinctive appearance with a large head, tall stature, learning disabilities, developmental delays, cognitive limitations, and advanced bone age. And for most pediatricians, they can reflect on their practice and say they see a lot of kids who are tall and they have a large head, they have learning disabilities. But I'm going to try to convince you of how distinctive this is. There is a distinctive MRI finding with large ventricles, corpus callosum anomalies, extracerebral fluid. The key thing is that they're usually large at birth, and it's the head that is the most distinctive. The macrocephaly is the most distinctive feature. Some nonspecific things, scoliosis, flat feet, very, very slight increase in tumor, 1 to 2%. And the disability generally looks worse because they're hypotonia, and they tend to get better. A lot of information available online, Gene Reviews, OrphanNet, very active support group, SOTOS Syndrome Support Association. So this is a series of photos of children that I've known over the years. I'm just going to show you them. I'm not going to say anything and see if you can appreciate their similarities. And I would say that your eye is probably drawn to the upper third of their face. the prominent forehead, receded hairline, real or subjective hypertelorism, small chin, and over time it gets more prominent. This young lady, whose pictures are actually in the Smith book, shows you her appearance over time. And most people say that that doesn't look like there's a syndrome there. That's one of the reasons we included this in the Smith book. We wanted to help people remember that syndromes are not often strikingly abnormal. You have to be just aware of what's going on. And of course, what's missing from this is the inability to hear her, watch her walk, and follow her over time to appreciate what makes her have SOTOS syndrome. The SOTOS syndrome face is what we call an inverted triangle because of the prominence in the upper third and the way it is narrow in the lower third of the face. And this is really what speaks to me as a geneticist when I'm seeing the child. Note that the child is tall and how it accelerates. But I reassure the families that these children are not giants because the tall stature does taper off. This child was chunky, so there's a problem with obesity. But this is really what is most striking, is the macrocephaly, quite large. But again, eventually it does taper. This is a woman who was referred to me at age 65, I think, and we eventually reported her because we believe she was the oldest reported woman with SOTOS syndrome. And we confirmed her diagnosis with the gene test, but really what made the diagnosis was her photo album from childhood. And I hope you would agree that these pictures, these faces, really were similar as the ones that I showed you earlier. This is a gentleman that I followed. Now he's 31, and I had him standing next to the door deliberately because I wanted to show that although his head was still at the 97th percentile, his height tapered off. He is not a giant by any means. There's a distinctive brain in SOTOS syndrome. They do not have a large brain. It is not megalencephaly, but they have a large skull. So what happens is you get large ventricles, you get extracerebral fluid, and you do get a small corpus callosum there. We'll move on to something completely different. CHARGE syndrome, formerly known as CHARGE association, described by Brian Hall and Hittner in the 1970s, by Bonnie Pagan in 1981, and is memorable because of this acronym: coloboma, heart, choanal atresia and stenosis, retardation, now we would prefer to call it intellectual disability, and this R includes the CNS anomalies, genital, ear anomaly. And this kind of illustrates how we try to come up with acronyms that are memorable, but we sort of force the acronym. Because we now know that the C also includes cranial nerve 7 palsies. It gives them a face. Cleft lip and palate, TEF and GER. So CHARGE is certainly memorable, but there's more to it than that. And now we know that there's a causative gene. It's called CHD7. CHD does not mean congenital heart defect. It refers to a type of a gene. It is sporadic. It is dominant. There are examples of gonadomosaicism where the parents seem to not have the gene, but they will have children. It will have more than one child. I urge people to avoid overdiagnosis. There are times where people will say, well, a child has a small ear, and they have a narrow nose and a PDA. Is that CHARGE? And it really isn't. You need to really adhere to the criteria, which we'll talk about. These children have tremendous multisensory deprivation. They're often thought to have quote unquote mental retardation, and they often have much better cognition than they're given credit for. Lots available online, and the CHARGE Syndrome Foundation has tremendous information and tremendous support. So one of the reasons for talking about CHARGE is to illustrate how criteria evolve. So in the beginning, in 1979, there were the original CHARGE criteria. And we would say that somebody needed to have one or two of the main features and maybe three of the others. But it evolved. I was part of this study group in 1998, and we talked about the major criteria: coloboma, choanal atresia, characteristic ear, and then we learned about the importance of the cranial nerve dysfunction. Anosmia, can't smell, asymmetric face, cranial nerve 7 palsy, the deafness, and we learned that their swallowing problems were probably on the basis of a cranial nerve. We were always interested, or I was always interested, in the heart defects because they sometimes resembled the DiGeorge syndrome. So we had genital hypoplasia, the developmental delays, the heart, growth deficiency. We became aware of the cleft, the TEF, and this face, we started noticing that they had a very similar appearance. Uncommon findings sometimes overlap with the DiGeorge syndrome. Thymic, parathyroid hypoplasia, renal anomalies, occasionally some hand abnormalities. I mentioned that they had a similar appearance, abdominal defects, spine abnormalities. Now, this was before the gene was found. And then in 2007, criteria were developed that reflect where we are right now. We still feel that the major criteria are the choanal atresia and the ocular coloboma. We now know, I'm going to scoot down here, I want to emphasize that in addition to the 7th cranial nerve palsy, we have learned that hypoplasia of the semicircular canal is almost pathognomonic. So things have changed from where we were talking about these 4 out of 6 criteria to where we are right now. A lot of focus on the cranial nerve 7 palsy, a lot of focus on the semicircular canal, as well as the coloboma and the cranial atresia. For a talk like this, there's not enough time, nor is it appropriate to go through these things in great detail. So I leave you with the message that there are criteria, and they can be very useful for a child who is sick in the newborn period. Let's look at these. Let's look at some of these faces. So this is a composite from an article in the American Journal of Human Genetics in 2002. And I think if you look at these faces, even without going through them individually, you will sense that there's something about them that looks similar. These children have a tendency to look upwards. They have ptosis. They also have a coloboma in the retina, which means that part of their visual field is cut. And they're looking, they're searching for their visual field, and they often tilt their head upward. Their face is flat. They tend to have a cleft, which gives them that flatness there. There are their ears, and they have asymmetry. This is a typical malformed ear in charge. It's not a normally formed ear. We sometimes say that it's squared or windswept. This is something that we call a hockey stick crease. It's by no means pathognomonic, but it's more common in charge. These are 3 different children with charge. This is a young lady who has had some ear surgery, another young lady who shows the cleft, and this child had striking overlap with the DiGeorge syndrome. This is a trach there, a cleft. The heart defect was an interrupted arch. This little boy was somebody I met at a meeting, and he was on the floor. And he was assuming a position of comfort because he had a posterior fossa defect that made him unstable. These children are very unstable because they are deaf and blind. We often say hearing impaired, visually impaired, but there is a community that calls itself deaf-blind. They cannot smell, and they have poor balance. And for this reason, they really go through life with tremendous sensory challenges. And they often will prefer to be on the floor, supine, anything but upright. To switch gears, I'm going to talk about Noonan syndrome, which I do believe most pediatricians have heard about, learned about, or possibly follow in their practice. And I know it might be pushing the boundaries to talk about these other related syndromes, but the purpose of this is to illustrate this concept of a family of related disorders. So there's great history to Noonan syndrome. It was described by Jacqueline Noonan, a pediatric cardiologist, in 1963, and probably before then too. And we thought there was one gene, then there was another, and another, and another. And these are pronounced PTPN11, SOS1, RAF1, KRAS, SHOC2, NRAS, SIBL, and RIT1. And each of them is slightly different. There are not strong genotype-phenotype correlations, but there are some. And it's beyond the scope of this talk to review them. But the common theme is that, first of all, this is a single gene, which means if you have it, we think of autosomal dominant transmission, and a person has a 50% chance of passing it along, and we would look at a person's parents to see if they might be affected in a mild way. Short stature, variable performance, the facial features, which I'll show you, ptosis, the droopy eyelids, low-set ears, down-slanted eyes. Heart defects include pulmonic stenosis, secundum-type ASD, also VSD, tetralogy of Fallot, and in addition to structural heart defects, hypertrophic cardiomyopathy. Pectus, scoliosis, cubitus valgus are the skeletal features, and there can be a tendency for bleeding. There are many other different features, and again, for the interest of time, I'm sort of highlighting the most common ones. Tremendous phenotypic overlap, especially in the very young, and diagnostic labs recognize the fact that there can be this, challenge. It's not possible to pick out one particular gene So what we do is our labs offer a panel, a Noonan syndrome panel, many of these different genes. The heart and cancer phenotypes are variable, but it's important to diagnosis because they can impact prognosis and survival. And the references include gene reviews, OrphanNet, very active individual groups such as Noonan syndrome, COSTELLO CFC, and they have all banded together to form a Rasopathy network. So some photos. Here is a mother and a son with Noonan syndrome. You could easily look at them and not realize there was anything about them that is different. This is short stature. He has pulmonic stenosis. This young lady has Noonan syndrome. She's, you can see her in a book on pediatric cardiology. I thank my colleagues Ron Lacroix and Amy Roberts for this. And she has the hypertelorism. She also has an interesting feature, which are these very blue irides. It's an interesting sign that we see. You can notice that her ears are low set, and she also has a congenital heart defect. This child illustrates the type of webbing that we see in Noonan syndrome. It's a prominent trapezius muscle. This is a pectus. Notice how it's an S-shaped. Superior, it's prominent here, and then it's excavatum here, so I'm trying to draw an S. And there is a keloid here for the sternotomy scar. Here is a daughter and her mother who have the same PTPN mutation. And here you may not even notice that she had anything that was different about her. Hemostatic abnormalities are common in Noonan syndrome. You can also see lymphatic dysplasia, nevi, cafe au lait macules. Cancer can occur, ALL, as well as juvenile MML. This is a poster that I obtained from the Noonan syndrome website. It's a wonderful illustration of the tremendous variability in the appearance of people with Noonan syndrome. This is a facial appearance that you might think of as classic because the woman has the striking hypertelorism. And yet this woman, who was her daughter, shows a milder form. Here is somebody who might look more typical. This child shows you the challenge that we have in trying to diagnose Noonan syndrome in very young children. And this person shows no features at all. These intriguing little bubbles are my way of showing you with Venn diagrams the overlap. Neurofibromatosis, which occurs in about 1 out of 3,000, is in fact one of the Rasopathies. Noonan syndrome is actually more common, 1 out of 2,000. There's something called Noonan NF, which actually straddles both. This is something called Leopard syndrome, which is an allelic form. CFC, Costello syndrome, the KRAS mutation, and disorders I haven't mentioned, something called Leigh syndrome caused by spread 1 capillary malformation. Again, this is more than one would include for a typical review of syndromes, but I think the concept is visually presented there. So Noonan syndrome illustrates the concept of molecular genetic heterogeneity, one syndrome with multiple genes, and it certainly shows a great variety in the expression and also the breadth of the phenotypes. PTPN11 is an example of allelism. We have 2 disorders, Noonan and Leopard, with the same gene, and these are allelic forms. Just a very quick view of some of these related things, related syndromes. Costello syndrome would probably differentiate from Noonan syndrome because of this bubbly, friendly personality, a slightly different facial appearance. Costello syndrome, the children have grooves on their palms and their feet. They have tremendous laxity. They're similar but different. In the CFC syndrome, CARDIO-FACIO-CUTANEOUS syndrome, there tend to be more ectodermal features. Sparse curly hair, eyebrows and lashes, hyperkeratosis, keratosis pilaris, nevi, and ecthyosis. And so this is a child and his friend with tremendous curly hair, somewhat of a Noonan syndrome face, but a little bit different, and 4 other individuals, again, the curly hair here. So I'm going to switch to a completely different syndrome, which is called HOLT-ORAM syndrome, described in 1960, caused by mutations in TBX5. And this is also a single gene syndrome. There seems to be something we call anticipation, which is the phenotype may be more severe with subsequent generations. This is almost always a disorder of upper limb abnormalities. rare examples of lower limb. It's usually bilateral. The left side seems to be more severe than right. It can involve thumb absence, hypoplasia, or a triphalangeal finger-like thumb. The bone that is most typically involved is the scaphoid, but also the radius, humerus, and clavicle. And the heart defects, which is part of the heart hand, it's usually an ASD, often a VSD, but can also include a partial anomalous pulmonary venous return and also complex heart defects. And we see conduction defects too. No dysmorphic facial features, tremendous intra and interfamilial variation. Radiographs are essential, but wait until after infancy because many of the small bones are cartilaginous and would not be useful. If TBX5 is negative, we have to look for other causes, need molecular testing. And again, references on gene reviews and Orphanet. There's an HOLT-ORAM support group in the UK. So here's an example of somebody who has two thumbs, but this one is hypoplastic. Here's a young boy, and one of the things you can see is he had a sternotomy for repair of his heart defect. You can see that the angle of the hand is different because of radial aplasia. Sometimes the expression is called a radial club hand, but we refrain from that. And so you have a finger-like thumb here and an absent radius and an absent thumb. And here's another child displaying radial anomalies, absent thumb there. So HOLT-ORAM syndrome can result in both structural heart defects as well as rhythm problems. About 80% any type of a heart defect, septal defects, ASD secundum, membranous, also muscular though, partial anomalous pulmonary venous return, complex heart defects, and conduction defects. And this is just a little diagram of a pretty typical ASD secundum in the mid portion of the septum, and just a reminder to think about the heart defect, the conduction defect, which is a first-degree heart block, so for prolongation of the interval. So to typify or to exemplify a skeletal dysplasia, I've picked osteogenesis imperfecta. And they feel that there are writings as far back as the 19th century where there have been examples. In 1928, there was a man of glass that was described. In 1979, the Sillins classification was used. So these are disorders of collagen, collagen A1 and 2, collagen 1, A1 and 2, and most of them, usually mutations, also deletions. And there are many other genes, though, that have been described. So we used to tend to think of the four types. Type 1 is mild, non-deforming, collagen 1A1. Type 2 was the perinatal lethal. These would be observed in stillbirths or in the immediate neonatal period. Type 3 is called severe deforming, and then there's moderately deforming. But there's really been an explosion, and so now there are at least 12 types. I won't review them each by name, but just to convey the concept, but this will continue to be, I think, an expanding group of syndromes. And they can be autosomal dominant or also recessive. So you absolutely have to be working with a knowledgeable geneticist and genetic counselor. But the common themes are bone fragility, blue sclera, bone deformities, joint laxity. This is not too common, the mitral valve prolapse. The aortic dilation is actually not completely well defined. Progressive postpubertal hearing loss. Dentinogenesis imperfecta in some. The differential diagnosis, though, is familiar to pediatricians, which is non-accidental trauma. And there are also some other disorders, juvenile osteoporosis, leukemia, hypophosphatasia, and Brooks syndrome. And reading material is easily available, gene reviews, Orphanet, and a very active OI Foundation. So blue sclera is a feature that pediatricians are taught about early on. And oftentimes this is something that we see just based on ethnic background. It's difficult to capture in photographs, but I think I can show you two good examples. Sometimes they're just mildly blue-gray, but oftentimes they're just strikingly blue. And I'm going to show you two children there. This is a young man who is an actor, Atticus Schaefer, and I obtained this from a commercial media, Parade magazine. And he's been in a TV show called Malcolm in the Middle. I like to show examples of people who live with genetic conditions to make the point that genetic syndromes are things that people do live with and can live well too. And he's very open about it. This is just to show you the website for the OI Foundation, and I love this expression, unbreakable spirit. Shows you a young man here as well as a woman too. And again, it shows you people living with a condition, not just as patients. That's type 1. This is sort of a memorable radiograph that I think everybody has had a chance to learn about in their training. And this type of a crumpled bone typifies what we would see for OI type 2, the severe lethal. And this is a person, a baby from postmortem, and this is another child too. Now, somewhere in between is what we call type 3, and these are called severe deforming. This is courtesy of a colleague of mine, and this is the mutation that was found. I found this memorable article in the New York Times this year. The type of OI that he had was not specified. I don't know if he had a very severe type of type 1 or if he was actually living with type 3. But it describes this gentleman as having been born with OI, commonly referred to as brittle bone, and his niche in the world was as a coder, but also his struggles too. It was a very moving article. So the next syndrome is APERT syndrome. And APERT is a memorable syndrome, but I'm also presenting it because it represents the FGFR-related craniosynostoses. So it was described by a Frenchman, APERT, and it refers to mutations in FGFR2. So FGFR is a group of growth factors, and this is FGFR2. And there's phenotypic heterogeneity. So different mutations in this gene can cause APERT syndrome, CROUZON, Pfeiffer, Jackson-Weiss, Behr-Stevens, and isolated coronal syndrome. So this is a lot for us to be thinking about when we evaluate a child with craniosynostosis. It's a single gene, and this is an example of a syndrome that is associated with increased paternal age. So it's a classic craniofacial appearance, bicoronal craniosynostosis. But more important, and I think really unforgettable, is the severe bone and cutaneous syndactyly. Developmental delays and intellectual deficiency is common. There are CNS anomalies, choanal atresia, midfacial hypoplasia, acne, clefts, heart defects, and they need to be offered vigorous and early surgical management. This is a commitment of many years to multi-specialty care, several international support groups. So I can start by just refreshing your memory about the different types of sutures. We have the coronal, metopic, the lambdoidal, and in the midline, the sagittal. And this is a diagram, and this corresponds to the actual skull sutures. And when depending on whether one of these is fused, you get a difference in the skull shape. So we're talking about today for APERT syndrome is a result of bicoronal fusion and this shape of skull. So if you have sagittal suture fusion, you would get an elongated skull. And these are some illustrations from an article by Dr. Cohen, who's an expert in craniosynostosis, and I've selected the ones showing APERT syndrome. And in particular, I just want to highlight this type of syndactyly. You know, you hear the word syndactyly, and there are many different forms, cutaneous, bony, but this is almost like it's called a mitten hand because it's so severe. And the shape of the face is flat. There is exorbitism. There is midfacial recession. In profile, it is concave. And there is fusion of the coronal sutures. Here's another child with APERT syndrome, and you can see the fusion there and there. The facial appearance, I think, looks much milder than the ones I showed you before because it changes with time. And this is a picture of the dramatic intraoral abnormalities and the problems with the teeth. So one of the lessons to be learned with APERT syndrome is that the problem is much more than what happens to the membranous bone in the skull. There's abnormalities of the endochondral bone underneath. Now, different from CROUZON syndrome, but different from APERT syndrome is CROUZON syndrome. So you get similar bicoronal craniosynostosis, but no limb involvement. And here is a child who had this, and here he is in the presence of his mother. So this sort of captures the natural history of what happens when this is not treated. but their hands are normal. Here's another girl who had CROUZON syndrome, and this shows you the appearance again of an untreated craniosynostosis. So the final syndrome that I'd like to review is fetal alcohol syndrome, sometimes said FAS, and it's really part of a broader fetal alcohol spectrum disorders. It was characterized in 1968 by Lemoine and 1973 by Jones et al. And the cause would be maternal ethanol. The inheritance is related to whether the mother is using this teratogen. The diagnostic criteria are prenatal growth deficiency, microcephaly, short palpebral fissures. And there are different guidelines from the CDC, the National Institute of Medicine, from Seattle, where Dr. Jones had practiced and which continues to have a very active research interest. And there are different terms that have been used. Fetal alcohol syndrome is still a common term. We usually don't use the term fetal alcohol effect. There's the fetal alcohol spectrum disorders, alcohol-related birth defects, alcohol-related neurodevelopmental disorders. And these last two terms are actually very useful. So what we see in the face is ptosis, a smooth philtrum, a short nose, and a thin upper lip. There's a distinctive pattern of malformation and growth restriction and neurobehavioral impairment. You can see oral clefts, heart defects, clinodactyly. There's a national organization for fetal alcohol syndrome. This is a nice cartoon, nice illustration that's available online from the AAP. And it shows you the microcephaly, a low nasal bridge, epicanthal folds, some minor ear anomalies, and a small chin. This is a thin upper lip, smooth philtrum, and short palpebral fissures. A palpebral fissure is the width of the eye. From the inner canthus to the outer canthus, this distance is the palpebral fissure. And here is a girl that I'd once cared for that I think is just an excellent example of the same picture. Epicanthal folds, hypertelorism. She has a sleepy look, and that's what we mean by mild ptosis. Note the smooth philtrum and the thin upper lip. And she had an ASD secundum. These are the atrium. This is her echo. And this is another feature of FAS. This is camptodactyly. These are stiff fingers. This child is not able to put them flat onto the table. And I leave you with this final slide to illustrate FAS, which interestingly was from the National Geographic, February 1992. This is a famous photographer, George Steinmetz, and he titled this "The World as They See It." I thought this was a memorable quote. When Malcolm was born, I thought my heart would break, she said, and oh my God, the guilt. And two other photos. It's important, I think, that as we learn about different conditions and how they present, we try to remember the difference in their appearance in different ethnic groups. Much of dysmorphology and syndrome delineation depicts only Caucasians, so I think it's important to see different ethnic groups. But again, you can see in both of these children, I think the wide-spaced eyes, the flat philtrum, and the thin